So next presenter is Dr. Ramesh Venkatesh. Is he here?
Yeah. Shall I start? Sorry, the first one was overshot. Okay. Good morning, everyone. My presentation for today for this free paper session is Lincoff's rule is not followed in pediatric rhegmatogenous retinal detachment. My name is Ramesh Venkatesh, and I have no financial interest. Let me start this presentation by paying tribute to Sir Harvey Allen Lincoff, who is considered to be the father of retinal detachment surgery. And the reason being what he gave us is the Lincoff's rules, which are applicable for subtotal retinal detachments, for superior retinal detachments, and for inferior rhegmatogenous retinal detachments. These rules were based on the configuration of the RD, the location of the retinal break, the SRF flow, and the gravity, which is primarily determined by two important factors. One is the vitreous syneresis or the liquefaction, and the second is the posterior vitreous separation. These rules were initially framed in 1971 in adults with rhegmatogenous subtotal detachments and in phakic eyes. However, these rules were further extended in pseudophakic eyes in the year 1994. And what is important is that these rules were framed basically for adult rhegmatogenous retinal detachments. But children are not small adults, and hence the RD in children do not have the same causes, vitreous dynamics, RD configurations, and surgical outcomes. And hence, with this study, we wanted to validate the Lincoff's rule in pediatric rhegmatogenous retinal detachments and look at also factors where in cases where the Lincoff's rule were not followed. Coming to the methodology, this was a retrospective study of pediatric cases diagnosed with rhegmatogenous retinal detachments between July 2017 to February 2022, and the documents of these medical records of these cases were scrutinized, and only cases with having good preoperative fundus drawings and accurate documentation of the intraoperative findings were included in the study, whereas cases with poor documentation, combined retinal detachments, and recurrent retinal detachments were excluded. The data documentation included demographic data and ocular data consisting of refractive error, lens status, and history of trauma, and preoperative fundus drawings on the Amsler's chart. This Amsler's chart was done in the OPD if the patient was cooperative, and in the OR after inducing the general anesthesia in cases where the patient was not cooperative for preoperative fundus examination. The retinal findings which were documented were the location of the retinal breaks, whether it is anterior or posterior to the equator, freshness of the RD, the bullousness of the RD, the PVD and the PVR status, and in cases where the retinal break was not identified preoperatively, the suspected location was made based on the Lincoff's rule, which is applicable for the adult rhegmatogenous retinal detachments. The intraoperative notes which were checked were for the primary retinal break and the missed retinal breaks, and then we compared the findings of the preoperative retinal break and the intraoperative retinal break and to check for the validity of the Lincoff's rule in these situations. Coming to the results, we had 98 cases of pediatric rhegmatogenous retinal detachments, of which only 40 eyes could be included for analysis, whereas the remaining 58 eyes had to be excluded. And what you can see from this table is the demographic data of the 40 cases of pediatric rhegmatogenous detachments. And you could see that the most common cause for the trauma most common cause for the RD was trauma. And in phakic lens and macula off detachments were most common, with superior detachments, fresh RDs. And what is important is that the preoperative identification of the retinal break was possible only in 35% of the cases, and the preoperative posterior breaks were only seen in 10 out of those 14 cases. Intraoperative retinal breaks were not seen in 8 eyes. That means these 8 eyes had to be excluded from the analysis, and the agreement to the Lincoff's rule was possible only in 9 eyes, whereas no agreement to the Lincoff's rule was seen in 23 eyes. So a Cohen's kappa statistics was done, which was 0.41, which showed moderate agreement, which belonged to the moderate agreement category. When we further analyzed the cases, we found that patients with high myopia, superior RD, and those with posterior retinal breaks did not follow the Lincoff's rule. A further multivariate regression analysis identified the inferior RD and the anterior location of the retinal break was associated with the cases which followed the Lincoff's rule. So coming to the summary, the results, it showed that there was only a moderate level of agreement of the Lincoff's rule in pediatric RDs. The agreement was possible only when the brake is anteriorly located and there was an inferior RD, and no agreement to the brake in myopic cases, superior RDs and posterior retinal brakes. Coming to the discussion, the RD configuration basically depends upon the flow of the SRF, which depends upon the location of the retinal brake and the PVD status, and therefore the adult rhegmatogenous retinal detachments and the pediatric rhegmatogenous detachments cannot be compared. In our study, in patients of pediatric RDs with myopia, we found that the PVD was present and the location of the brake was more posterior, and hence the Lincoff's rule was not followed in those cases, whereas in traumatic pediatric RDs, the PVD separation was not complete, the anterior location of the brake in terms of dialysis or large brakes, and hence the Lincoff's rule were followed in those cases. The study has got a few strengths and weaknesses as well. The strength being, this is the first study to be reported in literature which talks about the validity of Lincoff's rule in pediatric RDs. And second, and the weakness being the small sample size and the retrospective studies designed because the small sample size, because we were having strict documentation as one of the most important inclusion criteria. So to conclude, Lincoff's rule is valid in most of the clinical scenarios except in majority of the pediatric RDs where it fails to identify the exact location of the retinal brake due to its posterior location and absence of PVD. A careful observation of the retina is a must intraoperatively to find any missed retinal breaks. Thank you so much.
Good paper, Ramesh. Can you tell me what was the age group that you involved in your study?
So, ma'am, the range of the patients which were included were between 5 to 18 years.
5 to 18 years. And the possibility of not finding a break was because they were children and they were not allowing you examination, or was it something else?
So the reason we did not find a break in the sense, so the patients who were diagnosed with the reg RD, they underwent examination in two ways. One, in the OPD itself when the breaks were not visible, and second, even intraoperative, means not intraoperatively, preoperative, after inducing the general anesthesia to the patient, we did the indirect examination and tried to find the breaks. But in some situations, even on the preoperative examination, we were not able to, under the general anesthesia, we were not able to identify those breaks.